devastating side effects after treatment, not only during the chemo and hormone therapies, but afterwards. And a lot of these therapies, particularly the biological therapies, are being continued long term. And so there's a whole new specialization in medicine called survivorship, because we're now converting large proportions of the population from being healthy, getting a diagnosis of cancer, and then the treatments are causing numerous long-term toxicities such as obesity, we just heard about obesity, but fatigue, not sleeping, osteoporosis, nail changes, all sorts of things. And there's a lot of burden on themselves, most importantly, but a lot of burden on the health service. People don't realise that the cost of cancer care is actually largely dealing with the patients afterwards. For example, we're spending £1 billion a year on statins. I'm not saying these are all cancer patients. 800 million on diabetic drugs, 80 million on laxatives. Now forget about what it's going to cost to leave Brexit. If we can get people to stop taking laxatives, we probably have the answer. And it's not just about the drugs; it's to do with empowering patients. If you talk to patients and they've decided to embrace lifestyle changes, they do feel empowered. So even if it's not working, they're still getting a benefit. And a significant small group, which is increasing, are looking at nutrition, exercise in particular, and possibly some supplements and overall well-being. But the talk today, I'm just going to concentrate on phytochemicals and polyphenols, which is the remit, because we can talk for hours on weight reduction and exercise, etc. So phytochemicals, these are the chemicals, as you know, within food, which are a gift from nature to us. They make food look nice, they make it taste nice, they make it smell nice, and actually have numerous health benefits as well, ranging from reduction in heart disease through to cancer. So I'm just going to explore some of the data, as Martin has very eloquently described. There's not a lot of randomized data here, but I'm just going to look at some of the cohort data. We know from studies such as the Health Professional Follow-Up Study, which is following 40,000 professionals over 30 years, then you can look at different aspects of their life, which people tend to have cancer or not, and it quite clearly shows that if you eat lots of tomato-based or colourful fruit, you have a lower risk of prostate cancer. The same applies for people who have soya products. They have a lower risk of breast cancer and other cancers. But it doesn't actually stop there. If you look at cohort data of people who have healthy diets after cancer, they do have a lower risk of relapse. For example, the soya studies, cruciferous vegetables, it was a study from Australia showing if you had skin cancer, you're less likely to get another skin cancer. People who drank tea, so these are polyphenol-rich foods, they're not just fruit and veg. If you drank tea, you have a lower risk of breast cancer relapse. So one of the first things we did in our institution, we have a research lab now consisting of doctors and nutritionists, is we did an evidence review, which we published in British Journal of Medical Practitioners recently, looking at all that data I've just suggested and more. And we also tried to categorize polyphenols and phytochemicals, which was actually quite hard because there's lots of different definitions of what a phytochemical is, but this is how we split them up. It was polyphenols, terpenoids, thiols, and other phytochemicals, and we looked at the individual evidence for each of those chemicals and how they have an anti-cancer effect. So you're very welcome to look at that data if you get a minute. You can download it actually from our website as well. Now Martin's already very, in fact much better than me, explained that these foods do have direct anti-cancer properties. Now, many people use the term antioxidants, which of course is one of the attributes of these foods, but it's by no means probably the strongest, and it's by no means the only attribute. But nevertheless, it is important. If you eat, we know from cell line data and also from animal data and some human data, if you eat sort of a beetroot-rich diet, and then you give, this is in rats, you give the rats a carcinogen which would induce esophageal cancer, and the rats which were randomized to beetroot don't tend to get the esophageal cancer, which the others who didn't have the beetroot did. So, and there's numerous studies like that to show that the antioxidant properties are important. They do mop up the free radicals, putting it simply, before they damage the DNA. But phytochemicals have other attributes such as the phytoestrogen properties, which you get in flax and soya, lentils and things, We know that that has a weak binding to the estrogen receptor. It blocks the endogenous estrogen, and it does prevent some of the downstream pathways which result in hormone-related cancer, such as breast and endometrium. We know that these foods have reduce chronic inflammation. They can affect the COX-2 levels and prostaglandins. So we've just heard that chronic inflammation, particularly if you don't exercise or you're sedentary, is a risk factor for cancer. They also affect the expression of our genes within our DNA. So of course we're born with susceptibility for cancer, and some people are more likely to get cancer than others, but you can, a good poker player will tell us that you can actually you can deal with the cards you've been dealt, because certain foods affect how those genes are expressed, the unfolding of the DNA. And as again Martin's already said, many of these foods have direct anti-cancer mechanisms. This is putting rather simply, and it was described better before, but say for example we've gone out and had a Pringle, a Coca-Cola, and sat in the sun too long and had a barbecued sausage, so we're doing everything we can to try and cause cancer to ourselves, which is what most people do in the summer. But that cancer's formed. Most of the time our immunity mops up that cancer cell, but for that cancer cell to then progress and to proliferate faster, bring in new blood vessels to feed itself, to lose the adhesion from the site of origin and metastasize, and eventually the burden of disease so much it would actually cause organ failure and kill you. That pathway has to go significant further genetic mutations and biological processes, and those are the processes I feel lifestyle has some impact in changing. And that's and you think, well, this is new, this is sort of state-of-the-art conference, but this was actually 2 centuries ago when the forefathers of medicine, Stephen Paget, said, let's stop trying to look at the seed, which is the cancer. Look at the soil. Every good gardener knows that you can have a good seed. If you've got bad soil, it's not going to grow. So our bodies, we need to make it to be bad soil for cancer to grow. So how can, I'm not going to talk about the other thing, because this is only the nutritional part. When we talked to patients, we talked about weight reduction, stopping smoking, exercise, but just concentrating on nutrition. How can we increase the polyphenols and phytochemicals in our diet? Well, you can just eat more of it, which many people don't want to do. And certainly the patients I see 45 patients in a clinic and do spend time in each one talking about diet, and probably about 15% will listen. The rest will just carry on doing what they want. But if in that group you can make vegetables, etc., into soups, which increases the polyphenol intake. This is becoming more popular. We can obviously concentrate foods by liquidizing them. And certainly for a research institution like ourselves, we are interested in concentrating whole foods into supplements. Now I'd like to, Martin quite rightly said, supplements, there's no evidence, etc. Yes, it is true, but you have to not put supplements all in the same category. I mean, there was a study, a scientist from Sweden I was quite appalled to see, who was in their national newspaper when I was giving a talk last week, saying, don't take supplements if you've got cancer. He'd done a study in animals on vitamin E, and he's extrapolated the data from vitamin E in an implanted tuber that people shouldn't eat vegetables because of their antioxidant properties. And this is what you hear all the time. Of course, there are different types of supplements. Supplements which people are familiar with are mineral and vitamin supplements, where you concentrate a chemical out of food and you concentrate it into a pill, or there's supplements which just literally concentrate whole food. They're very, very different. We know in terms of micronutrient deficiencies, etc., we know it's important. If you're a sailor in the 17th century, you would die of vitamin C deficiency. There's still rickets, which is commonplace around the world. So we do know you need adequate amounts of vitamins. We also know there's areas of China with low selenium, and they have higher incidence of cancer. And there was one study which corrected selenium in one village, and they actually had a lower incidence of subsequent cancer. So we do know these are very important. But in a Western population like ourselves, most of the trials which looked at giving mineral and vitamin supplements against placebo in cancer prevention did not reduce the risk of cancer, and worryingly, studies like the SELECT study, which was vitamin E and selenium, increased the risk of prostate cancer. Studies of vitamin A increased the risk of lung cancer. So it doesn't look like, saying that the EPIC study got it right, which wasn't a prospective study, but that showed if you had low folate, you had an increased risk of cancer. But if you took folate supplements and you had too high an incidence serum level, you had an increase in of cancer. So it's best to have it right. So coming on to the whole food supplements, which are literally whole food, dry it, take the sugar out and concentrate it. Do we have the evidence? Well, probably no. I was lucky enough to be invited onto this committee, which is an NHS committee similar to the one you were chairing, Martin, which was called the Complementary Therapy and Lifestyle Clinical Trials Committee, where we decided to try to look at various factors of nutrition and to design or advise the design of clinical trials and get some more answers. So we looked at all the foods, well not all the foods, many foods over an 18-month period, and we came up with a league table of which whole foods had the most evidence. Now this is evidence from cohort data, from animal studies, and from very limited phase 2 clinical studies. But as just said, green tea, curcumin or turmeric, pomegranate and broccoli sort of got to the top 4. Of course there could have been another 50 on top of that, which are all sorts of colourful fruit teas, etc. But these are the ones who sort of made it to the top 4. So what we decided to do is concentrate it, put it into a whole food supplement, get it manufactured to a level which is required for a medical study. So it had to be sourced very thoroughly, had to have if you concentrate foods, you could concentrate the pesticides and the contaminants, of course. You had to measure those, and you had to test that it was what it says it was. You had to test it for authenticity, and we had to do mass spectrometry to actually measure the phytochemicals to make sure they are at a very high grade. So it was actually quite difficult to find someone to make that supplement. We eventually did find some, and we were able to do a randomized, double-blind, placebo-controlled trial. We started with men with prostate cancer who weren't on any other treatments. So either men who had an early prostate cancer who didn't need intervention at that point, or they'd had intervention, they were relapsing, but we didn't want to start treatment. And after just 6 months intervention, there was a very significant difference in their PSA, which is a marker of their cancer, between the group given what is now called POMI-T and the placebo. We're very pleased that the following year, so this was 2014, publication was 2015, we were invited to give one of 10 talks in ASCO. ASCO is probably the best cancer conference in the world, certainly the most prestigious, and they invite 10 talks for that year to present on any trial. It could be medical, usually medical, and we were one of those. So although people say there's a conspiracy against lifestyle and nutritional studies, if you design it powerfully enough, you link it with government organisations and it's sufficiently audited, and then you will get given a platform. So we're very proud of that. One of the things which came out is they said, well, you just affected PSA, even though AstraZeneca got their license for Zoladex, their $2 billion a year drug, on PSA alone, but of course a nutritional study couldn't possibly have that in it. So we then had to do a further study looking at annual MRI scans to show that the PSA had 100% correlation with underlying disease on MRI, so it wasn't a PSA effect. We're pleased to say that that product was then commercialised. Of course, we're a small hospital in Bedford. We're not going to go and set up a factory making it. So it's now gone out into the big wide world, which makes it available and, of course, can be made by anyone because these things are not patented. At the moment, it's made by Helsinn in Switzerland and Italy. And the only sort of caveat is they have to stick to that quality, which was in the original study. And actually, fair play to them, they're doing a lot more as well on top. Also, in terms of recognition of this, we're very pleased that the NCI, National Cancer Institute, which is regarded as one of the best institutes in the world for information to patients, features this trial as #1 on their advice for patients with prostate cancer. In Sweden, it's in their national guidelines for prostate cancer, and a very good organisation called Memorial Sloan Kettering features it 4 times on their complementary pages. So it's getting, it's a small study. I have to say it would be nice to get a confirmation data, but it's got legs and it's gone out into the big wide world. What are we doing next? Well, We published in Adelaide this year looking at the level of side effects people get after hormone therapies from cancer. Hot flushes seems to be the most troublesome. Arthralgia, I'm glad someone said 55% earlier on, because if you look at the data sheet compendium for the drugs, it says about 20%, but in the real world, arthritis is a very common side effect of cancer treatments. And this was a study we published in Liverpool last year, asking patients why they didn't exercise after cancer. Well, some just don't want to, but up to 40% said they don't exercise when they've got arthritis, which you caused, so it's your fault, which is true. So obviously we can give them non-steroidals, which give them renal failure and heart attacks and indigestion, or we can try to look at lifestyle factors to reduce arthritis. So another part of that study is we ask people, what are you taking? Is there anything you're taking that you think works? In men, obviously, it's biased by the fact they were taking Pommy-T and all the things to try and stop their cancer progressing. But in women, which is probably a more accurate picture, it's very much geared. If you took a supplement, probably about 20-30% took them anyway, but most people took supplements because they had a symptom. In fact, you looked at people who didn't have symptoms, the amount of supplement taken was only 20%, but it was nearly 80% if you did have a symptom. So patients are going out there, going over the counter to say, I've got arthritis, what have you got to help me? Now, it's fair enough saying, well, we're not going to do any research on this, but people are doing it anyway, so we have to do research on it because that's what patients want. So we worked with the Arthritis Research UK, so what's working and what isn't. Glucosamine, chondroitin, and fish oils were the most commonly taken supplements for arthritis. And there are some studies to say they help, but overall the conclusion was of doubtful benefit, I'm afraid. Fish oils seem to help rheumatoid. But then they've issued a very nice document, actually, and I'd recommend anyone reading it, looking at foods which are likely to help arthritis. And actually, it's the same foods which seem to help cancer. So don't put people into little compartments. They've got arthritis there and they've got cancer there. We're all sort of one happy sort of family, aren't we? So these foods have anti-inflammatory properties. We've just showed that. They have antioxidant properties. We know that the reason why you get arthritis is you can go and have a toxin induced into our body or a stress from trauma, and that initiates an antioxidant process which damages cartilages. We know that these foods, again, trigger an apoptotic effect, so it encourages the cartilage to eat itself up, and part of the enzymes which do that are metalloproteinase. And all these sort of foods have an influence on this as well. Is there any truth in that? Well, we didn't specifically measure arthritis in the trial. We asked them if they had any toxicities. We have had lots of people emailing to say our arthritis feels better when we take Pommy-T. Of course, that's just anecdotal, but it's interesting. We've also got cyclists who swear by it, who say that it helps their joint pains. This is the guy who cycles around the world, and he said he's halfway across America, he took it, and we didn't ask him to do this, by the way, or the company didn't ask him to do this. He said Neil felt better, and he went on. So, there may be some evidence, but, there may be some reports, but no evidence yet. So, this is our next study, which is starting in January. We're looking at, we're going to get 210 men and women with breast and prostate cancer. We know that we're going to give them hormones and they will get arthritis within 4 months on what we're giving them. We know that from historical data. So if you're doing a trial of looking to see if an intervention prevents arthritis in the general population, you probably have to wait 10 years. But we've got a perfect model in cancer patients. So we know they're going to get it within 4 months. So the intervention is going to be using the Macmillan Move More program to encourage people to exercise. So they'll be referred to a gym or a local exercise group. They'll have reinforcements to exercise every month. They'll be given a Fitbit to remind them to exercise. And so they're all going to get that. We know that that only works at a small percentage, so we'll get data on whether that intervention works as well. But in this group, we randomized them to a pill which is full of phytochemicals similar to the Pommy-T study. Now the endpoints, this is a multiple intervention and it's going to be multiple endpoints, because what we're hoping, this is only a hypothesis, that they won't get so much arthritis and then they will exercise more. So we're not saying that this intervention will prevent that. What we're saying, this intervention will allow them to exercise more, and if they exercise more, they will have less weight gain, there'll be less fatigue, they get less peripheral neuropathy, less likely to fracture their hip and end up in the hospital with a superbug, and they'll get less depressed. So that's starting next year, so we're excited about that. Just in the last minute, say it's not all about putting phytoestrogen, phytochemicals into your mouth. We can actually use them topically. This is what happens when we give Taxotere to patients with breast and prostate cancer. It's not very pleasant. Most of the big pharmaceutical studies are not interested in anything like this. They don't make any money, certainly not interested in topical creams which you can't patent. So we've come up with a cream which is a polyphenol-rich cream which we're putting on the nail beds before chemo starts, and we've just actually finished recruiting this, and we're hoping to publish it in ASCO next year, and we're looking to see that you can sort of put a local antidote onto the nail beds against placebo and to help that very troublesome side effect. We don't know the results of that yet, but I think it'll be in May, ASCO. Just for the last minute, randomized trial is the gold standard of information, the source of information, but saying that, I'm a busy oncologist. I see 40, 50 patients a day, and I hear their stories, and still these stories actually, to me, strike a chord. And this is this is not a minority of patients. This is patients who embrace lifestyle. I see this a lot. On that caveat, of course, there are many people who embrace a healthy lifestyle and their cancers progress, and just like what they do. So it's not a case of making people feeling guilty if they don't embrace lifestyle. But now and again, you see remarkable stories. This is a man, for example, he had hormone refractory prostate cancer. He'd had all the hormones, he'd had Taxotere chemotherapy, he'd had 3 doses of radiotherapy. So this is not an early cancer which you read in the Daily Mail where you could have done anything and they were red. This was end-stage prostate cancer. His wife started making him broccoli soup every morning. A year later, nodal disease in the abdomen better, PSA reduced to 0.2. 7 years later, still alive and well, now progressing, going on to abiraterone. 7 years of good quality of life, only change in treatment, broccoli soup. He started taking that later, but it was already had the intervention done. This is another patient who came to me for palliative chemotherapy who was asymptomatic with lung mets and liver mets from colon cancer from a few years before. I said, look, I can poison you with chemotherapy, it's going to make you feel ill, it's not going to cure you, or we can wait a little while, and gave her the opportunity to go to the gym, stop sugars, increase her polyphenol intake. 2 years later, metastasis is smaller, we've still got chemotherapy on the shelf to give her if she wants it. And I was interviewed in Sky the other day and say, well, you're talking about low volume prostate, the easy disease. This is probably the most remarkable case. That's 2 years now, woman with metastatic breast cancer to her brain, who had no change in treatment at all. I wanted to give her radiotherapy, she declined. I wanted to give her chemotherapy, she declined. She went out and she joined a gym, she walked 3 times a week. She really did everything you possibly thought. She was found to be vitamin D deficient, she did everything. 2 years later, mets have not grown. Okay, this is a select group, but it just gives you hope that there's perhaps more to these foods than meets the eye. So that's the end of the talk. If you want any information about our ongoing research program, the best way is to follow us on Twitter or Facebook via that website. As I say, please don't ring us about this product. It's got its own website. My research manager will actually resign if she gets another phone call. Thank you very much.
Really impressive results you showed with the committee in prostate cancer. Looking at the underlying mechanisms which might be there, the theories thereabout, do you think it will work the same on other types of cancer, or is it too early to tell?
Well, one of the reasons I've got the case reports at the back, I deliberately picked patients, well, apart from the first one with prostate, he had metastatic, of course, and the trial wasn't with metastatic patients. So certainly in prostate, we think the intermittent hormone therapy group will get a big advantage. So where you have hormones for a year, then you take them off them, and we think that's extending significantly when they need to go back on hormones. So that's just finishing off in prostate. Yeah, I mean, when we looked at the data, we weren't looking at prostate. We just started prostate because it was the easiest group to do the trial. The trouble is you can't put a woman with breast cancer and say I'm going to randomize you to a broccoli pill or not. It's not going to happen. So one way we could look at it is tumours with a high chance of relapse, like bladder tumours or skin cancers, where 60% of them will get another cancer within a year or two. And that's the group where we're going to sort of move on to next. So the next big trial is going to be the arthritis and well-being, and then funding and time allowing, yes, I'd love to do other tumour types.
Okay, one more.
Considering the POMI-2 daily dose, how much of the products that you use to create the supplement you would have to eat to have similar amount of active ingredients?
Well, this is a common question, of course. Within that product, they reject a lot of suppliers, so they only take the ones which are very high in polyphenols. So, whereas when you buy broccoli from a supermarket, you don't really know, do you? And from one year to another, or one field to another, it could change quite dramatically. But as an estimation, it would be something like a bowl of broccoli a day, a half a teaspoon of turmeric, which of course you take in the morning and lunchtime. So you're sort of arming yourself up. Earlier in the day, you would normally eat those sort of foods. Most people have a bowl of Rice Krispies with sugar on it, don't they? So they're arming themselves up with carcinogenic things to start the day. So it's you could compensate, of course, and we always encourage people to take NutriBullets, that sort of thing, and eat lots of fruit and veg. But it just gives you that extra level you probably wouldn't do on a normal basis.
Okay, thank you very much. That's the end of the session, so please join me in thanking all the speakers.